liaison role, nurses particularly in Argentina, and the early recognition of sepsis. As a part of her PhD study at Griffith University, she tested a qSOFA-based sepsis screening tool in general hospitalised patients. In addition, Laura has led the formation of the Latin American Federation of Intensive Care Nurses, formed in 2006, and supported it since. And she is a World Federation of Critical Care Nurses Honorary Ambassador. So we're delighted to have you here, and we're looking forward to your presentation today on the accuracy of a qSOFA-based sepsis screening tool.
Thank you. Thank you for, good morning everyone. Thank you for this presentation. I am presenting, as Glenn said, findings on the accuracy of a qSOFA-based sepsis screening criteria. These are preliminary findings of the nurse-initiated sepsis screening study that started in 2015. Sepsis is a life-threatening condition that occurs when the body's response to an infection damages its own tissues and organs. 30 million are affected every year, 7 to 9 million do not survive, and survivors suffer lifelong consequences such as disability or post-traumatic stress disorder. Sepsis is becoming a common condition in hospital wards. Hospital ward patients are activating rapid response systems, and they are presenting poor outcomes. Previous described tools were mediated by technology, paper-based and nurse-led, and they were all described in only one country. These tools had great variation in their accuracy performance. In 2016, the clinical criteria for diagnosing sepsis has been redefined. Within these changes, 3 clinical variables, high respiratory rate, low blood pressure, and altered mental status, were proposed as a quick sepsis-related organ failure assessment, or qSOFA, to help sepsis recognition outside intensive care. Most of what we know about sepsis comes from research conducted in developed countries. Limited evidence suggests that sepsis is more prevalent in poorer and lower-income countries. So to address this gap in science, in knowledge, the aim of this study was to test the diagnostic accuracy of a sepsis screening tool that incorporated qSOFA and the presence of confirmed or suspected infection in general hospitalized patients in a developing setting such as Argentina. Using an interrupted time series design, I collected data from April to November last year from 5 hospital wards in Buenos Aires. Patients of 18 years or older were included. Patients from coronary care, intensive care, emergency department, obstetrics, pediatrics, neonatal were excluded. And they were excluded because their physiology response to sepsis is different than the general hospitalized population. Patients under palliation or with sepsis diagnosis by the time of admission to the study wards were also excluded because they were not suitable to answer the research question. The sepsis alert criteria consisted of the presence of 2 or more qSOFA points. That is 2 of these 3 criteria, either high respiratory rate, altered mental status, or low blood pressure. I collected the qSOFA variables of all patients during the entire admission. To build the sepsis alert criteria, I chose the very first 2 qSOFA points. I also collected the source of infection as clinicians were documenting these sources in patients' clinical record. This sepsis alert criteria was then compared with the blind diagnosis at discharge conducted by an experienced intensivist who was unaware about the behavior of the qSOFA variables. The study was approved by Griffith University, ethics body, and Argentinian ethics body. Over almost 800 patients are included in this preliminary analysis. Overall, patients had a median age of 70-year-old. More than half were female and medical. They stayed in hospital a median of 4 days, and almost 10% required ICU admission. Sepsis patients were older, the majority of them were medical, had more comorbidities, and stayed in hospital longer. And those who require ICU admission also stayed in ICU more time, and 4 of the sepsis patients died. Regarding the sepsis alert criteria variables, overall, 34% had one source of infection. Almost 10% had 2 or more sources of infection. Almost a half had antibiotics prescribed, and almost 20% were qSOFA positives. And 97 patients, that represent 13% of the sample, met the sepsis alert criteria. The majority of sepsis patients had one source of infection, but 1/3 had 2 or more sources of infections, being pulmonary, urinary, abdominal, and bacteremia, the more common sources associated with sepsis. The final accuracy analysis was calculated in 769 patients. Among them, 15 were true positives, 82 were false positive, 11 were false negatives, and 661 were true negatives. This resulted in a quite modest 58% sensitivity, a quite good specificity of 89%, a very low positive predictive value of 15%, and a very good negative predictive value of 98%. While sensitivity was low, further analysis combining sensitivity and 1- specificity in a narrow seed test resulted in a reasonable and statistically significant area under the curve of 0.751. This means that qSOFA performance is quite good to predict sepsis diagnosis at discharge. This is the first study testing qSOFA performance in general hospitalized patients in a developing setting. While the prospective data collection makes the study bolder, there are some limitations to acknowledge. The sepsis alert criteria included the suspicion of infection, and the infection was not confirmed in few cases at discharge. There were 1 qSOFA point patients that had one criterion not available. They could have met the sepsis alert criteria. Different sources of information and seasonal variations could have influenced the number of septic patients or the number of sepsis alert patients. In conclusion, qSOFA has modest sensitivity. It's very good ruling out non-septic patients. There is a concern related to the use of qSOFA as a screening tool because of the low sensitivity. But given the reasonable predictive ability, I can propose qSOFA can be used in general hospitalized patients with an additional prompt or alert mechanism to address the low sensitivity. And finally, I believe qSOFA has a value in other settings where no other alert mechanisms are in place. With a picture of the doctors and nurses that made this study possible, I thank you. I'm happy to answer your questions.
Thank you so much for the presentation.
Thank you.
I'll open up to a question from the floor.
So on your second last point there, you suggested another robust trigger or mechanism for that's all right. Oh, okay. So on your second last point, you suggested another robust measure for screening for sepsis, what would you suggest would be that robust measure?
Oh, Gavin, thank you for the question. It's an excellent question. Well, sepsis, the problem we have with sepsis is that sepsis has there's no pathology test. There's no biomarker we know that can help us. It has different, the initial signs can be subtle. And this, I know there are other tools that have been used on variables that have been used, like early warning systems that are being reported in the literature as have been more sensitive and better prediction performance. So I think if qSOFA has to be included, could be on that area, but it needs obviously more examination and in different settings. But I'm saying what I'm reading in the literature, but we need more because qSOFA in my sample couldn't identify hematology failures or renal failure or infections because of viruses. Those 11 cases that were not identified. So I think it's, if I'm answering properly, I think if there is criteria would be in the direction of those that are already tested, like in line of the early warning scores. But I can't say what variable specifically, because it has to be simple, it has to be doable, it has to be sustainable, it has to have a low cost.
Okay.
Laura, I've just got one question. I just wanted to talk a little bit about the differences between Argentina and first world countries where
Yes.
research has been done. If you can just, because it seems to me it's almost not a third world country, it's more second world with a GDP that's going up. And do you think it's soon that that the country will become more, I suppose, developed?
Thank you for the question. It's an interesting, we had last year a 40% inflation rate, so that makes you a future difficult to plan, and the health system is fragmented. The study was conducted in Buenos Aires. To give you a difference, I had 3 different sources of information, with some information being not available sometimes, and that makes challenging to implement quality improvement projects and also collecting data. The average time that took me to collect this data was 12 hours per day working, every day. So that gives you an idea about the challenges. There are no support. Additional clinicians are most of the time on their own. They are the doctors, nurses, minimum admin support, and just only doctors and nurses, no other aid staff. And that's in Buenos Aires City. I'm talking about one of the, in a big city. Yeah. So well-resourced in comparison with others. The public system is worst. It's more challenging even. So it's, I don't know if it gives you, it's just
no, that's great.
The difference.
Any more questions?
There's another question just here. Maybe the final question, just so we can keep progressing through the speakers for the session.
Okay, thank you for interesting talk. I'm just wondering if you have compared qSOFA with other sepsis screening tools like SIRS or SOFA, other?
No, I didn't. I know SIRS is more sensitive, but it can be too sensitive. That's the criticism. And with the changes in the definition of the sepsis 3 definition, the criteria to diagnose sepsis, and the challenges, there was no point. There's too much research in comparison with SIRS. So qSOFA now are being compared with other tools, including SIRS as well. But for the study side, for the hospital I was going to implement the test, it was a little bit challenging, and it was not suitable because it was not the intention to compare with SIRS.
Thank you so much. Thank you.
Thank you.
Please
Thank
welcome
you.
the presentation.